Welcome, Mangla Bharati, sir. So happy to have you with us, sir. Sir, can you unmute yourself, sir?
Hello, good evening, everyone.
Yes, sir. Good evening, sir. So can we start, sir?
Yeah,
A
please.
formal welcome to all, and then we can move over to your presentation. So everybody is looking forward. So on behalf of the IAP CCB, I deem it a great pleasure to welcome you all to this ninth in the series, the P3 series, Perspective for the Pediatric Postgraduate Decoding Diseases. And on account of, newborn week and commemorating the same, we thought it would be appropriate to have a doyen from neonatology speaking to us about optimizing transition advances in delivery room neonatal support, none other than our Mangla Bharati sir. He's the professor and head of the department, neonatology, IOG. He needs no further introduction. He's well known for his talks, succinct presentations. So over to you, sir. Thank you for joining us today, sir.
Yeah, just 1 minute. And that's ready.
So can you check if you're able to share the screen? Otherwise, we'll make you the co-host and enable your sharing, sir.
So, are you able to see my screen?
Yes, sir.
Okay, do you see the topic?
Yes, sir. Yes, sir. Yes, sir. Clear, sir. Over to you, sir.
So, is the audio clear?
Yeah. A little louder, sir.
Okay. 1 second. Is it better now?
Yes, sir. Yes, sir.
Okay. Yeah, very good evening, one and all again. My profound thanks to IAP Chennai City branch and the office bearers for having given me this wonderful opportunity to interact with you all. And as already been pointed out by Dr. Lakshmi, it's an additional pleasure that we are discussing this topic. We just finished the celebrations of National Newborn Week from 50th to 21. I understand actually this is primarily a postgraduate program. And if my understanding is right, most of you joined here or postgraduates in pediatrics, maybe some in neonatology. My intention and my preference will be to I won't take more than around 35 or 40 minutes. So what I'll try to do in this time is mostly try to give you an overview of actually what is happening in this domain of giving care to a newborn in today's delivery room. To start with, okay, so what is special about this delivery room scenario, right? Whether you are a neonatologist or a pediatrician, whatever the kind of settings you are working in, it may be a medical college or it may be, you may be primarily into an OPD practice also. But at some point in time, most of us happen to be there in a delivery room taking care of a newly born baby. So no doubts that both the training curriculum of postgraduates and all the quality measures whenever they are brought in for certifying any pediatrician. So the skills of a person, a pediatric trainee or a pediatric physician, in especially in a delivery room scenario, are very, very profound and important. I'll say even though things look very simple when you look overall, or when you look from outside, the core concepts is very, very simple. So what we need to do in a delivery room, so just only the first, if you remember the first one, that's more than enough. All that we are trying to do as a pediatrician delivery room is that we try to understand how nature would have done this transition of a baby from an intrauterine environment to this extrauterine environment. As long as things are going fine, we should just be simple bystanders. And all that we should be doing is aiding the baby in or allowing the baby to make this transition, which is aided primarily by nature. Our role kicks in only when you realize something goes wrong, the transition is not happening in the way it is intended to be. In that scenario, if we believe that the baby might get into a trouble, so we step in and we start bringing in some support measures to the baby, so to facilitate this process of transition. As I said, in a nutshell, all that we need to ensure is that the normal physiology of transition happens without any interference as far as possible. So that's very logical. It has a lot of challenges, right? So how good are we as humans in mimicking nature or winning over nature? Nature is a huge force. So whether you believe in God or you want to call it as by any other name, this is, or at least you can put it in this way, whatever happens in nature is not happening just by chance, right? So this is happening as an end result of a knowledge that had been accumulated or gained over millions or billions of years or repeated generations. So this organism or the environment has understood how things should happen, and all that amount of knowledge is what we call as the nature, what is happening in nature. So when we try to mimic nature, when you want to, or when things are not happening and we want to replicate it, many times we end up in one of these two, right? So either we may understand how to do things because just we are trying to only copycat nature most of the time. But the challenge is that what is doing it in the optimal way or the same way that nature does. So we tend to err on the side of one of these two. So either at times it becomes, what to say, we are over enthusiastic. We give more support than compared to what is necessary actually. So that itself can cause a lot of damage. And the other side, if you're not giving adequate support, that may result in the failed process of transition. So that is that's more or less true about the whole of the neonatology. Trying to support a baby, trying to optimize all the interventions, what we are trying to do in the care of a newborn. So the optimization is something that stands in between overdoing things and inadequate or underdoing things. Always trying to strike the balance between overdoing and underdoing. More so in a transition. Why again things are more challenging? Because see, as long as the baby is in the fetus, in the in utero environment, so all these support systems, which are performed by the various organ systems of the body, as humans, we evolved in a way, we do have specialized systems exclusively meant for managing various. Sorry, somebody is trying to speak to me. Oh, okay, yeah, we'll continue. Yeah, okay. Can you please just keep your mics in on mute, please? Okay. So, for example, here we all know respiratory system, cardiovascular system, gastrointestinal system. There are n number of systems in our body which perform their unique functions. But for the fetus, all these are taken care by just one organ, this wonderful organ placenta, which takes care of respiration, which takes care of most of the, nutritional support, which functions as an excretory organ. So the fetus has a lot of, the organ systems developed. It is not that they don't have those organs, but they're all overtaken by this wonderful placenta. And this simple process of just once the placenta is removed, all these individual organ systems should start doing their job in the right way. That's what, in one word, we call it as transition, right? So unfortunately, again, so when we need to do it artificially, we can't do it in the way a placenta does. We need multiple support systems meant for respiratory support, cardiovascular support, nutritional support, blah, blah, temperature support, thermal regulation. So for each and everything, we are bringing in artificial supports. If that is the scenario of even what happens in an NICU for most of the time, just imagine the scenario in a delivery room. So what are the difference between an NICU and delivery room? At least in an NICU, I'll say it's a more controlled environment. We do have a reasonable amount of time. And most importantly, we all would have had a look at the kind of machines, the size of the machines and the support systems. So how far will you be able to bring or move all these machines into that small delivery room where it is available, and trying to optimize all these machines and monitors? So, even though the newborns have got a very immature or diseased state of organs, they are somewhat predictable. No? Nothing is going to change very drastically over a period of seconds to minutes, unless it is a very new complication like a sudden IVH, which do happen very rarely, once in a while. Most of the time, even if a baby is getting sick, you will be able to anticipate what is happening, and you will have a time in terms of minutes to hours to respond. But in a delivery room, in this process of the so-called transition, there's a hell lot of a change happening here. So the lungs, which are filled with fluid, have got a very different kind of a dynamics inside. The moment the baby comes out, all this fluid has to be cleared by some mechanism, and should be filled with air. Gas exchange should start taking place. The skin is very wet. And in a delivery room, we happen to see a baby which may be anywhere between 500 grams to up to even 5 kgs, right? So it's 10 times like you are managing a 5 kg baby in a child and a 50 kg child. So obviously, they will be different, right? A lot different. So that much amount of differences may be there in the patient characteristics. And to top all of this, the cardiorespiratory system, the primary system, is in a transitioning phase. These are the major challenges in the delivery room. Something like this. See, it's just like walking a tightrope, as I said, not falling on the side of overdoing and trying to, this side, this is underdoing, and the other side, it is overdoing. You try to keep there. This I'll say it's true. As I said, this is a picture which depicts the NICU scenario. If this is the NICU scenario, it's more difficult in the delivery room. It's not only just trying to navigate a rope in air. It's about just very special skills where you just try to walk on a wheel which is actually moving on a rope. That kind of expertise is what we are looking for when we talk about managing these very fragile babies in the delivery. Okay, so before getting into the specific, I may not be spending enough time, because intentionally just I avoided this. Dr. Lakshmi, if someone can help me, do you see what I'm writing here? Is it there on your screen?
Yes, sir. Yes, sir.
Yeah,
Your board
fine.
is working fine.
Board
Yes,
is
sir.
working. Thank you. Great. All of you, I think, are having enough opportunities, as it is mandated in your curriculum, to get certified in this NRP program. And as science evolves, as more evidence keeps pouring in. The recommendations of this neonatal resuscitation program keeps changing. And I'm quite sure that you will be very much aware of what are the recent recommendations or the changes that are happening in this field of neonatal resuscitation. So my primary focus will not be in this domain of the neonatal resuscitation. So as I believe all of you have to go through the whole program in detail. This is not something where it is okay for you to have an idea about what is happening. This is a mandatory domain, mandatory field. All of you have to get trained. All of you have to get certified. Maybe just we'll spend a minute or so trying to understand. Okay, you all know that what is new happening in this NRP of late. The changes are more or less, it is again what I say, the core principles remain the same. So what do you mean by core principles? It is always a ventilation oriented or trying to open up the lung. That is the single most important step in resuscitation at any point in time. That's what we need. Once it happens, all the steps follow automatically. So what are the new changes that are coming in? So we seem to be the way it is being given, the number of cycles you give, looking for chest expansion and all, it's all happening. But the trouble is in optimizing the respiratory support. Respiratory support remains the core. So we know that when the traditional ambu bags or bag and mask cannot provide PWP, you won't be able to control the pressures during inspiration, what we call as the PIP, precisely in an ambu bag. So for a better control of PIP, controlled PIP, and for delivery of PWP, we know that. So this is possible only if we start using a TP's resuscitator. So most of our delivery rooms now, all of you are getting trained and you started using TP's resuscitators for providing the initial respiratory support when necessary for babies, more so for preterm babies. And that's number one. The second, obviously, we know that we have to be very, very careful. During support, it is not only about pressure, it is also about oxygen. So we need to have a pulse oximeter to target saturations in a delivery room for a newborn. And if it is a term, we are recommending starting with room air, no oxygen for resuscitation for term babies. Now we have in a preterm, we are talking about starting with a lower oxygen, something like 21 to 30%, and then trying to titrate or go upward as if necessary to maintain appropriate saturations. So that also, I think all of you will know that's been happening. And a lot of importance is given to maintenance of temperature when we talk about preterm babies. It's just a simple radiant warmer might not be enough to do that. You may need special devices, use of polythene wraps, thermal mattresses, that kind of systems in addition to the standard radiant warmer. A lot of developments are happening in that domain. And coming to this important component, which I will touch upon later also, placental transmission. Okay. So I don't have a very good handwriting, pardon me. Yeah, so we all know the importance of allowing the blood from the placenta to move into the newborn during the process of transfusion. So earlier versions of NRP were not very clear about what to say, this delayed cord clamping across all gestations. A lot of hesitations and queries were there, some gray areas were there. Now, at least in the recent version, the last, given a 2023 update that had been published, it's clearly said, at least for a baby who's doing well, a vigorous baby, what will be the gestation, you try to do a delayed cord clamping, at least 30 to 60 seconds, you just wait. If this baby happens to be a non-vigorous baby, still you can try to do a delayed cord clamping if feasible, if you have provisions to do it with special equipments and devices. If that is not possible, you go for cord milking. So the intact cord milking is something which is being recommended in the new NRP. The only contraindication is less than 28 weeks. We don't want to do a cord milking. There are concerns about a sudden increase in intravascular volume because of cord milking causing damage to the brain in form of intravitreal hemorrhage. So except in less than 28 weeks, all other babies, whether they are vigorous, non-vigorous, do delayed cord clamping. If that is not possible, at least settle for cord milking. This much amount of clarity has come in the recommendations of NRP. So I think that's the something in a nutshell. And this only one more thing, which is very, very interesting. I'll touch upon it a bit later also. So we have been struggling a lot when we talk about the right kind of interface for providing positive pressure ventilation. We know the device for providing positive pressure ventilation is TPs. We have an excellent device. But what are the interface that we're going to use? So these laryngeal masks airways are coming up in a big way when you're talking about, to the extent the NRP recommending this to be considered as a first choice for interface for providing positive pressure ventilation. So please refer to the latest 10-point update from the American Academy of Pediatrics. You will find considering LMAs as the first choice of interface for providing positive pressure. Okay, maybe if you have some queries related to NRP, we will take it up later at the end when we have some time for discussion. So I'll move to the other domains, as I said, where we have specific challenges and where some unique challenges are being offered by scientists and technology as options to manage those challenges. So as I pointed out already, the very difficult whenever somebody is doing a positive pressure ventilation. So what do you think is an expertise of a pediatrician or a trained person? Do you think there is somebody who doesn't know how to press a bag? Is that a difficult thing to do? So the single most parameter which determines the success of a positive pressure ventilation is how good you are in making a seal. That is the crucial thing. If a seal is made properly, obviously, when you are squeezing the bag, the air is going to enter into the lungs. So that is where people fail in their, I won't say they don't know how to make a seal. So many people, inexperienced people or people who are not formally trained, so they have difficulty in understanding that the seal is not appropriate, where they need to work on. Rather than focusing on the seal, people focus more on trying to do so many other things, and that resuscitation becomes a failure. So we have been going through, I'm not promoting any particular brand here. You look into the various kinds provided by different kind of manufacturers, all this one. Why do we have so many shapes? So people keep on experimenting with different kind of anatomical shapes of a face mask, which they believe will solve this problem of having a poor seal. But we are to each there. And it is, I think, I believe personally, it is what to say, maybe some shapes may give a little advantage over the other shapes, but it is not practically possible for us to keep all these shapes and sizes by the side of each and every baby and trying to switch or swap between one another to generate a good seal. Yeah. Okay. This is what I was just discussing a bit earlier also. It's a fantastic editorial. People who are really interested can go and read this editorial in detail. So at least the answer, I have given you the answer already, right? So we are not cool with just having this face mask as our first choice as an interface for the resuscitation at the time of birth. We need to explore other things. So there is a wonderful systematic review comparing the various interfaces apart from face masks which are available for giving resuscitation in the delivery room. And this is, I think, even before data on LMAs started coming in. So even binasal cannulas appear to offer some advantages over face masks in this systematic review. In the face mask itself to improve, because that is As of now, that is the ubiquitous device. So all of us, many of us are still using this face masks. We're yet to migrate to the other recommendations, or at least even to test the other ones. So in the existing system, look for at least a few things which will help you. One is I already discussed the various anatomical shapes that are available. The next one is the devices where you have something called as a, there is something, once you press the mask, it will generate a negative pressure at that point. Suction masks, it's okay, they provide a little bit smaller advantage. This is very fascinating. Yeah. What you see here is the same ambu bag designed in a different way. This is from Ledder. I'm sure there are many other products that have followed suit. So what is special? It just simply looks like the same bag, right? So it has been found that when you are talking about a normal ambu bag, so let's say this is the baby. Yeah, you are keeping the mask here and you are holding the bag on the other side. So what is it? There are two different axes, right? This is one axis. This is one axis. When we talk, I am talking about the bag apparatus alone. So you have a device which has two components which are aligned at a 90-degree angle against each other. So a small tilt in this component is going to cause leak in the other component. It's not possible to maintain this axis constantly, right? When you keep, and both these parts are mobile. You are holding one component in your left hand and other component in the right hand. So to get rid of this problem, can we just make the axis into a single axis rather than having two axes? So that's all the whole simple idea behind this having an upright bag. And studies have shown actually having this, using this kind of an upright bag, which has got a single axis, achieves a better seal compared to that of the conventional lateral bag. I'll just show you how it works in a simple small video. So were you able to see the video?
Yes, sir. Yes.
Okay. Thank you. Fine. So that's one way. So other people thought, okay, fine. And another wonderful innovation from India. Okay, obviously, Adderall is from the West. It's not our own innovation. So this innovation is from team. It's a collaboration between Stanford Biodesign Group and a team from the innovation lab at AIMS, Delhi. So which is being now marketed by, its marketing is done by Phoenix now. This is called Neopre. The concept is very, very simple, right? So even in a normal bag and mask, you would have seen this, no? So whenever you are not able to get a chest rise, what do you do? What is recommended? You take what we call as ventilation corrective steps, right? So you just see whether the seal is okay, the airway is blocked, you do a suction. You take corrective measures. Have anyone, if you have read keenly, there is one more recommendation in this hidden in ventilation corrective steps. Have you noted that one? Sorry. Okay, so you can go and read again, maybe in an NRP. If you're not able to, if chest expansion is not happening, consider using both your hands to make a seal rather than using only a single hand. So we all know they call these E's and C clamps and all, right? Rather than trying to struggling to just make a seal only with one hand, if somebody can use both the hands to make a seal, obviously they can make a better seal, which is a well-known fact. So can we just move the, what to say, pressure generator to the foot end and use both the hands to make a good seal. So this device is a foot operated device, just like pressing, rather than pressing with your hands, it is a foot operated system where you keep on pressing and shown to, you will be able to control the pressure as well, just like what you do in other kind of devices. And when in a study with health workers, it has shown, at least going by their, so why done on health workers? We believe there are people with lesser experience, and they are the ones who might have more difficulty. At their level, it has been shown this device achieves better seal than the conventional one. So that's something to ponder about. So the interface question is a question, is a work in progress. To summarize, we have started bringing in devices like LMAs, which will be more secure, still non-invasive. We are not intubating. That might be the future. They may become the first choice. The NRP is moving in that direction. We can use binasal cannulas to provide positive pressure ventilation. The face masks, understand the pros and cons. That is the standard as of now. I will say the standard. It is the most widely used interface as of now. But we can consider improvisations even in using the face mask for achieving a better seal. Why we are spending so much time on this single topic interface? That seems to play the crucial role in determining the success of any positive pressure ventilation in the delivery room. Fantastic. We'll just touch upon one concept. So we'll discuss another 4 or 5 concepts, and then maybe we'll open for discussion rather than just bore you with an one-way lecture. Okay, the other, we'll move now to this. Okay. What is the importance of providing a positive end expiratory pressure when you're providing a respiratory support to your newborn to facilitate or optimize transition? That's where this device has become our go-to device of our choice. Just like a ventilator, so you do have a manometer. You have 2 valves. You know that this is, this valve, no, which is sitting in the close to the patient interface where we hold. So this is the PWP valve here. By rotating this knob, we just either increase the PWP or decrease the PWP. Obviously, there is another knob sitting here, which is the PIP knob. And so we'll be able to adjust both the PIP and the PWP with this device called the TP's resuscitator. So widely used, fantastic device. And there is a manometer which is going to display both the PWP and the PIP. We know what values we're exactly delivering to the baby. Something like these are other innovations which we also have tried in some experiments here at IOG, some of our earlier DM thesis. Okay, can we add a PWP valve to an existing amber bag and make a simple kind of you can call this as a poor man's TP's resuscitator. You just see there are some adjustments here. There is a spring present here. Some numbers are written here. You just tighten that spring, you rotate it clockwise. It starts producing the amount of PWP which will be able to guide. And maybe if you add a simple manometer here, which is also now available as a small manometers can be attached to the bag itself, it becomes more or less like a T-piece. In spite of various experimentations, I can just tell you, so these were tried with a lot of hope, but we realized it is simple to buy a T-piece resuscitator than trying to make things more complex. Obviously, they are cheaper, but when you compare the amount of precision, so these devices are nowhere near that of a T-piece resuscitator. So I won't recommend going with the devices of a PWP valve and a manometer. Please go and buy T-piece resuscitators. They are getting cheap every day. What is this that is being shown here? One of the major challenges in TP's resuscitator is, so how do you, sterilize or disinfect this device, just like an ambu bag, between babies? We don't use the same circuit for every baby, right? Do we use the same circuit for another baby? So in a resuscitation scenario, how do you just, there is something, the air is coming through the TP's resuscitator, maybe the circuit part can be easily disinfected or sterilized. What about the valves and the other portions? The valve has to be, you can change the circuit, but the valve has to be there, right? It has to be the same valve here. So these are wonderful innovations which are available. Disposable TPs respirators, low cost ones. So use and throw. Very simple modifications. You just see the PWP valve and the PAP valve both fit in there into the same system. All that you need is just you need to connect it to a gas source. There is a display also. There is a small manometer which is there inbuilt also. It works well as a TPs. So from asepsis perspective, a good innovation. Disposable TPs resistors. As an extension of the concept of PWP, so why do we need PWP primarily? So we know in a neonatal resuscitation, this is what happens. To start with, the lung is fully filled with fluid. So gradually you start air replacing the fluid that keeps happening over each and every breath. One of the important determinants of this procedure is PWP. It is not PAP alone. So the pressure that is given throughout the cycle, PWP, plays a big role in this elimination of the fluid from the alveoli into the interstitial space. So, but PWP is being given only for a short time in every cycle, right? That's where people thought about this concept, calling as a sustained lung inflation. What is sustained lung inflation? Providing PWP for a longer time. You sustain the delivery of, because unlike inspiration and expiration, it's just like a CPAP with a higher level. You continue CPAP at a higher level. Sustained lung inflation gives some pressures, and whether that will help in better removal or pushing the fluid from the alveoli into the interstitium and start babies and a quick transition of the baby. That was the thinking process. But all of you would have, many of you would have heard about this trial. If you're not heard of the names, don't worry. It is a very, one of the larger trials which try to evaluate actually how helpful is this concept of the so-called sustained lung inflation during neonatal resuscitation. Unfortunately, actually, what we found, for want of time, I'm not showing you the results and all. This study was stopped midway because the number of deaths were more on the sustained lung inflation arm compared to that of the traditional PAP, PWP model of a TPs. So people said a big no for sustained lung inflation, even though physiologically we thought this may be a much better way of optimizing transition, but the clinical evidence is not for using sustained lung inflation in a delivery room, and it is nowhere recommended. So why did it happen, and what are the people trying to learn from this? That's where we are right now. So it looks like what we need is something in between the two. Just using a PAP and PWP like what we use in a TPs resuscitator is not good enough. At the same time, using a sustained lung inflation, the higher levels of PWP over a longer period of time is also detrimental. That is resulting in more deaths. So we are trying to tread a middle path, which is being called as an physiological based PWP, or some people call it as a dynamic PWP. What all that we are just trying to make use of is this principle of what is called hysteresis. Okay. Don't bother about this terminal. The concept is very, very simple, right? See, you may need what the principle of hysteresis can be explained in just 2 lines simply. When you want to open up the lung, just like you just see the curve during inspiration. To open up the lung, you need to use very higher pressures to open up the lung. Let's say I had to give pressures of 5 here, 10 here. This is the amount of lung expansion that keeps on happening during inspiration. But once the lung got expanded to a certain point, even if you come down on the pressures, the lung will stay like this for a longer time. That means for the same amount of pressure, so this at 2 points. During inspiration, for a pressure of 6, only this much amount of expansion is there. Only when I had to go up to something like 12 or 15, whatever you can call it, the lung opened up. But when I'm decreasing the pressure from here, even I can fall back to 6 and I can maintain the same level of lung expansion. So the so-called lung compliance curve, this is what is in a relationship between pressure and volume, the PV loop. It is not the same for inspiration and expiration. What does it simply tell you? Once you use high pressures, to open up the lung, but you don't need to stay with higher pressures to keep the lung open. Once the lung got opened, you decrease the pressures, even with lower pressures, you will be able to keep the lung with. So that is what the whole concept of a dynamic PWP is all about. So new experiments are happening here. So what are we doing? Again, it's a busy slide, don't worry. All that we're trying to do is that rather than keeping a single PWP or a very high single PWP like sustained lung inflation, for the initial few breaths, give high amount of PWP because we need to open up the lung. So once after a few breaths, you have to keep coming down. The PWP also needs to come down. You change PWP gradually. And then, so this kind of a concept is called as a dynamic PWP or a physiological based PWP. I won't be surprised if these concepts are brought in the next edition of NRP. You can expect these recommendations to come up soon in the next versions. I have some, and this kind of in studies have shown very good outcomes, like the need for mechanical ventilation for once admitted in the NICU, the need for high frequency, further doses, incidence of even conditions like BPD. All these have been found to be much less when you're using a concept of a physiological base or a dynamic PWP in the delivery. Fantastic. Okay, we have just only 2 or 3 more. I should finish in another 5 minutes. Are we okay with time, Dr. Lakshmi?
Yes, sir. Yes, sir. We have 10 more minutes, sir.
Okay, thank you. So, quickly, we have been repeatedly, what to say, in this process of artificial ventilation, positive pressure ventilation, against the way nature does it. Nature's breathing is a negative pressure ventilation, but all our ventilatory strategies use a positive pressure. So invariably, we end up in causing some damage to the lung. The more premature the baby is, the lungs are more fragile. Just using the simple process of positive pressure ventilation is going to have a long-lasting damage in these lungs, which is what we call as bronchopulmonary dysplasia or a chronic lung disease. They get stuck with repeated respiratory infections, poor respiratory reserves, and ending up in problems like, what to say, airway problems, wheezes, many things, oxygen dependency, so on. So we know in NICU, we give a lot of importance to targeting tidal volumes, right? We say lung protective ventilation, give a lot of importance to the so-called avoiding the volume trauma. We keep on watching the tidal volumes, and we have various methods or modes of ventilation which targets the tidal volume, which can automatically adjust the pressures to maintain consistent and low tidal volumes. So, what about delivery room? Is it okay to do this in the delivery room and control any amount of volume delivery and focus only on targeting tidal volumes once the baby gets admitted into the NICU? Obviously, studies have shown that most of the time, if you start measuring inadvertently, unintentionally, we have been delivering very, very high tidal volumes rather than what is necessary in the delivery room. That's very, very common. And that leads to lots of injury, at least in animal models, both lung injury and potential brain injury. This is the impact of delivered tidal volume about PPV in the delivery room. We are not talking about the pressures that are being used in the NICU. So that's where these devices will come soon into our delivery rooms. We call them as respiratory function monitors. What do they do simply? So these are some monitors, respiratory function monitors that are available. Simple, we can't bring in a ventilator into the delivery room. That's a bit tricky and difficult. But we can bring in flow sensors, and we will be able to have simple devices which tell you what is the volume that you are giving into the lungs. Some way of monitoring the tidal volume every time you do. So studies, simulators are already available to show that it is feasible. With many devices, I showed you one device already. This is a model of another device. Yeah, again, you just see It is on a mannequin where there are displays which show the amount of tidal volume given during each breath when you are doing positive pressure ventilation. The delivery, that much amount of air. So, okay, we discussed a lot about the pressures, interfaces, monitoring the tidal volume. Oxygen we discussed upfront only. But how are we sure that actually whatever we are delivering is helping in improving the status of the baby clinically? How do we ensure that this ventilation is optimal or adequate? Is it enough if you look into the tidal volumes or the pressures? Obviously, we know the single most important indicator of adequacy of ventilatory support is the heart rate. But only when the heart rate improves, that's the first thing to improve in any baby. So there, a lot of advances are happening. The heart, we know that NRP repeatedly says, gone are the times where we were palpating the umbilical cords or even using our stethoscopes. We now say you need to have ECG leads because it takes even a pulse oximeter is not good enough because the reaction time of a pulse oximeter is quite long. From the time you attach a pulse oximeter, for it to give consistent pickup of a heart rate, the time is around 80 to 90 seconds. Whereas an ECG is what I was talking about. In a pulse oximeter, it takes around 82 seconds, whereas an ECG gives a reliable heart rate in less than half the time. So that's why, again, the choice is an ECG, but it's not easy, right? In a wet baby, fragile skin, how do we attach quickly these, the various leads? Will they cause injury and how much time it will take to attach these leads? Lots of wires running and interfering with the process of resuscitation per se. So some alternatives are being discussed. So people are trying to embed the electrodes in the beds of the resuscitation bed only. You just place the baby there, electrodes are embedded, and it is going to display a heart rate. Those models are being tried. And this is interesting, right? I'll just show a quick, this is available, this device is available, right? So why don't we just, rather than having it as a complicated wire and an electrode system, can it be something like a simple plug and play device? It looks like, what are they, headphone, right? This is how it's being used. I'll just show you again. I'll run you through a small video. Okay, so we have such devices now available. You just apply it. Just it's something like just putting a headphone over your ears. You put this device over the chest. It gives a good display of the heart rate. Fantastic devices. A lot of progress is being made in the monitoring. So far, we have been talking only about the saturation, right? So what about CO2s? Can we start monitoring CO2s in the delivery room? Now we have sensors which can transcutaneous sensors available for delivery room where the monitoring of both saturation and carbon dioxide in the form of a PCO2 is feasible. The other alternate airways, I said LMA is coming up in a very big way. So this may be our go-to device as a first choice. The challenge only is in the size of LMAs, but we don't have a size which suit very small babies. But for most of the babies who are above a kilogram, it has been shown the current LMAs are good enough to be used as an interface for providing even positive pressure ventilation, not just as an alternate for ET. It is LMAs, all that I'm trying to say, they were, so far, they have been shown as an alternate to endotracheal tube, right? When ET is not available or ET fails, you consider LMA. But now the circle is turning back, the clock is turning back. LMAs will be considered as your primary devices for positive pressure ventilation. Only when we fail through an LMA, we may consider going for intubation later. This concept of resuscitation with intact placental circulation for especially non-vigorous babies, where we believe that, see, these are babies where the lungs have not opened up. Even if you're trying to ventilate them, they're already asphyxiated, their pulmonary blood vessels are constricted, no amount of good flow blood flowing
to take the oxygen from the lungs to the heart, the pressures are quite high. So why not make use of the so-called placental transfusion? So how is it helpful? So it keeps placenta is still working. It continues to give oxygen from the other end. It continues to provide blood, which is what do we do when a baby is in asphyxia? You give oxygen, you give try to eliminate CO2. When a baby is in shock, you try to give fluid bolus. All these things are done by placenta, right? One best form of a bolus is what? A blood. The blood bolus is coming from placenta. Placenta is giving oxygen. Placenta is trying to remove CO2. When it is a functioning placenta, why not we just keep the placenta functional till you just achieve the transition using these artificial systems. And once it been established, the baby is fine, then you go and interrupt the placenta. That's the whole idea of this concept of resuscitation with intact placental circulation. Many special devices, the devices shown here, or the Concord device from Holland, and we have one innovation from our own institute. We have developed a device in this record. So a lot of trials are happening, even though this is not a standard of care right now, but larger randomized control trials and larger trials are happening to see how good it will be when we are talking about non-vigorous babies. And let's wait for the results from these trials, and maybe this may be one wonderful intervention or innovation that might help these babies who are depressed at the time of birth. So for want of time, I was not able to discuss various other domains. A lot of work is happening in other kind of monitoring devices, like using techniques like a tomography technique. What does it say? A small strip applied over the baby can give you a picture which says how good the lungs are expanded, right? So you just see a right lung expanded well here compared to that of a left lung. So this much amount of information you just get by applying a strip using this principle of an electrical impedance tomography. Video laryngoscopes are very, very handy. So we need not have difficulties in airways. I intentionally didn't touch upon this very broad area of the role of artificial intelligence and the role of the simulator. Fantastic, mannequins and simulation systems are available right now, which can be used a lot for training people. Virtual reality, augmented reality, all are available. Even using techniques like eye tracking and heat maps. This just judges what the behavior of a care provider. You may be doing bag and mass, but where are you looking at? Are you looking at the chest? Are you looking somewhere else? All these things it is possible to track. Automated FiO2 controls, just like what we do in NSU. Their devices are becoming available for the delivery room. As I said, to integrate all these and to keep on giving suggestions, at least artificial intelligence may not be going to resuscitate a baby, but whether you are doing the things in the right way, trying to give you feedback in a real time. Do we need to do something differently? A has a huge potential. We talked about oxygen monitoring and CO2 monitoring. Why not directly monitor what happens to the brain? NIRS sensors, which are capable of being used in the delivery room. So I'll summarize here by saying that, see, this is a very, very exciting field, right? As I started upfront, I don't believe that in any point in time we will be able to win over nature. But we should consider nature as our biggest teacher, inspirer, and the mentor. We try to learn a lot from nature, and we try to use technology to mimic nature. But it's definitely a long way to go. All that again, but we can say with pride, we are making a lot of progress when we talk about use of technology right now and in future in the delivery room. And I believe strongly that with these advances, all of us will be capable of in a better position to help these babies achieve or optimize their transition process, especially when they are into difficulty. I'll stop here, and thanks again for the wonderful opportunity, and we'll take up questions if any or comments. Thank you.
Thank you so much, sir. As always, it was wonderful. I think, we were still in that MR SOPA level. now we have evolved to much advanced concepts thanks to your talk. So we know about intrinsic PEEP, we know about resuscitation with intact placenta and a lot of other things. Your points about the importance of PEEP, that was very, very, what to say, that everybody needs to know, sir. I think its importance in how it improves oxygenation, how it maintains the lung at the FRC, and then surfactant conservation, so many other things. So I think it's important for everybody to know the importance of PEEP also. So I think wonderful talk. We can take a few questions now if there are any. Feel free to unmute yourself and ask some questions. Any questions? If no questions, then can we wind up, sir, then?
Yeah, fine.
Okay. Thank you so much, sir. It was a wonderful talk. I really enjoyed it. And as I said, always you've spoken about basics and technological integration. So I think this talk was also one of that. The importance of initiation of early resuscitation, technological integration. I think, yes, that was the crux of it. Thank you so much, sir. On behalf of the IAP CCB, I thank, of course, Mangla sir for a wonderful talk. Thanks to all the participants. Thanks to our OB and EB members for coordinating this. The recording is available on YouTube also. So postgraduates who were on call, who were on duty, who couldn't listen to this wonderful lecture, please do log in to our YouTube channel. Please access our YouTube channel, IAP CCB YouTube channel, and make benefit. Thank you so much, and good night, everybody. Thank you.
Thanks, everyone. Good night.